All right, good afternoon, everyone, and welcome. This is our last session for today of the SCID Compass Summit. And joining us for this session is Dr. Yolande Walter. She is the Robert A. Good Endowed Chair, Division of Pediatric Allergy and Immunology, and Professor at College of the University of South Florida. Welcome, Dr. Walter.
Thank you. And I only see you and me as participants, so is it because there's a different button where the participants would be?
I think I will actually see our participants in the attendee hub, so I think we're okay to get started.
Okay, great, excellent. But I'm really excited to be here and to present to you some of our work, not just my work, but the work of our team here in Florida and beyond. This is about the travelers, United States family of Irish descent. And the work that I'm presenting to you was a joint collaboration with Dr. Stan Goldman and many of you who are probably even in the audience. So let's just start quickly introducing who we are collaborating with. Dr. Stanton Goldman is a principal investigator for the Children's Oncology Group at Medical City, Dallas. And he wanted to thank specifically Dr. Karl Lenarski, his mentor in Texas, who have been taking care of the Irish traveler families for a long time. I myself, I'm the Robert A. Good Chair of Pediatric Allergy and Immunology in Florida. And I have a fascination and a great interest in the Irish traveler population since the early times when I was reading National Geography. This is actually a beautiful picture of some of the children from Ireland. And I highly recommend you to read this review of Bertha Kaufman on the Irish travelers. And I would like to dedicate my talk to Dr. Luigino Tarangelo, who was my mentor at Harvard. He is an international SCID expert. And I also would like to dedicate the talk to the parents and family members of our patients. So let's just put into perspective of how we think about a close-knit community like the Irish travelers. If you look at other communities in the United States, the old order Amish population has around 344,000 members, and they are spread around the country, as shown in the figure in the left. And this population of the Amish population and the Mennonites carry several SCID and combined immunodeficiency genes, including ADA, RAG1, IL-7 receptor alpha, ZEP70, and CD3 delta. And it is a great example, the Mennonite and Amish population, how interesting when the SCID gene pool is increasing and there are several different variants circulating, and how complicated it is for the clinicians and even the families to decipher what is going to be a threat to them. The other interesting nation that I have been following since I have been training in the United States is the Navajo Nation. Jennifer Puck and Maud Cohen have been spearheading investigations on the Navajo Nations, which has around 170,000 members in their population. And they carry a very unique gene, Artemis, that now actually have a gene therapy protocol for. So the uniqueness of these populations sometimes also allow us to bring them targeted therapies. And the Artemis gene defect in the Navajo Nation was one of the reasons why the scientists in San Francisco could start initiating gene therapy protocols, and now it is in clinical trials. So we're going to talk about a unique population called the Irish travelers. And they are the smallest of the three populations that we mentioned. There are 75,000 of them in the United States and outside of the United States. The origin of this population is actually very curious. Within Europe, there was probably migration of these Irish travelers to other parts of the island, such as England, Northern Ireland, and possibly even to Europe as early as the 12th century, based on my personal communication with Sally Lynch. However, some of the Irish travelers actually reached the United States as well. And based on some of the recent reports, such as Gilbert's paper in 2017, mentions that probably this migration happened way before the Great Famine. However, it was not a one-time migration. What we know is that it's not uncommon for families to move back and forth between the United States and Ireland, and there were several waves of migration to the United States. Not only that, but the lifestyle of the Irish travelers themselves makes it much harder to understand their founder variants. Just an example, if you look at the map here, there are Irish travelers in Hagerstown, Maryland, in Murphy Village, South Carolina, in the Fort Worth area of Texas. And many of the family members not stay in the same area, but they move around based on their job opportunities. So unlike the Navajo Nation or the Mennonites, who tend to stay with their work, and the geography where they are is related to the agricultural work, the Irish travelers have a very different lifestyle, and their work moves them around the country. So what else do we know about the Irish travelers? This is sort of just interesting for me as somebody who likes science and who likes populations. The language itself is called Cant. It's a part of the Gaelic languages. In the US, they have spoken Cant words mixed with English. It is very distinct from other groups such as the Roma, Scottish or English or Newish travelers such as hippies. And the travelers themselves are in clan-like structures. This is very common in Ireland, maybe not as much in the United States. In the old days, they roamed the country by wagon, making their living as horse and mule traders. However, now they are a little bit more settled with work such as construction and home repair. In 2017, there was a big step when they actually recognized the Irish travelers as an ethnic group in Ireland, but they are still not recognized as an ethnic group in the United States. And overall, we know that there is a social stigma and discrimination happening against them in some parts of the US and Ireland. And this is an example of some of the movements when they were fighting for their rights. So the lifestyle of Irish travelers is captured in many contemporary art, narrative, and photography, and it reveals the life of a bygone world that is parallel to the modern Irish society. These communities now, as they are settling, they sort of lose some of the advantage that the closeness to the earth and to the agriculture brought them. And we believe that there is an increasing number of autoimmune diseases among Irish travelers because of the possibility of the changing microbiome. So the importance of the gut flora, the microbiome, and other non-dietary factors could be a risk for them to acquire other disorders or more metabolic diseases. So who are the Irish travelers in the United States? I was really impressed by this photography for one of the local papers. What I'm hearing is that having a wedding among the Irish travel community is a big feast where many of the community members are invited. They are very tight-knit regarding socialization, primarily Catholic by religion. The adults tend to stay at home until they are married, and they are much more for pro-life. That the divorce is rare, and they really join together in adversities. And I'm sure many of you who are in the audience who take care of families know that they're always there for each other to help out in hard times, especially when children are sick. So what do we also know about them is that in the Irish tribal population in Ireland has a lot of young children in their communities. Many of them, like 650 to 850, are born every year, but with very high mortality rate. And what has been sad for me to see is that 10% of the traveler children were dead before their second birthday. And the main cause of mortality were accidents, congenital malformation, and metabolic disorders. So it sort of speaks out for the importance of advocacy and education in this population, and potentially helping with their understanding of the genetic disorders that they could carry. In the United States, that is less known, but there is not as many severe reports as in Ireland. So I was fortunate to connect with Dr. Sally Lynch, who wrote this beautiful paper in 2017 on 104 genetic disorders in the family of Ireland. And just within that small community that I described to you, 104 genetic disorders are described, and only 50 of them were previously published. Many of these disorders are autosomal recessive, which means that you have to have both parents carry one disease gene, and then they pass it on to the diseased child. But 13 of them was autosomal dominant. And as we know in the field of primary immunodeficiencies, when you have an autosomal dominant disease, the likelihood of passing it on to the next generation is much higher. And therefore, I would not take this lightly that they had dominant disorders as well. Some patients have chromosomal duplications. And in this original report, there was no specific immune deficiencies reported. However, I will show you that further reports from Ireland has highlighted the importance of immune genes circulating in this pool. There are some regional differences in Ireland depending on what part of the geography of the island these patients are from. And you can see that even these disorders could be differentiated based on the area where they are, where the ancestry of the family is. And I do want to emphasize here this natural killer cell and glucocorticoid deficiency with DNA repair defects that was listed in the paper of Dr. Lynch, but the specific genetic disorder behind that was at that time not known. There are also some immune and infectious disease related abnormalities, hematological disorders such as Cohen syndrome, Fanconi anemia. And as we know, there's a really strong founder variant with adenosine deaminase deficiency among the Irish travelers. And this has been published now and was the basis of a newborn screening that Dr. Ronald Leahy and his group has established in Ireland. So currently, the newborn screening process in Ireland is not purely based on a track assay, but specifically looking for ADA deficiency because of the high frequency of this variant in Ireland and Great Britain. So what about the US? In the US, we had a history of following Irish traveler families since the 1960s. In fact, in 1965, Gilbert Oman from Harvard published an extraordinary report when he described a Catholic family with Rett disease. And in that family of 360 individuals, 12 infants were identified with a fatal disease that caused the accumulation of eosinophils and a syndrome that was later called as Oman syndrome. So the disease itself has been established, but it took us a while to understand the genetic disorder behind this Rett disease. We also know that in the United States, there are some smaller kindreds with a few family members described with natural killer cell deficiency. And these were recently published in both JCI by Dr. Casanova's team and Dr. Hughes. And these patients have not so much of a SCID variant, but more of a natural killer cell deficiency. No matter what, it is highlighting the importance of continually looking for important immune deficiency genes in this population. So I'm going to start describing to you our patient. The little patient that I took care of 2 years ago was actually a consul during the Christmas holiday here in Florida. He was a 7-day-old male born to the United States family of Irish descent. At that time, he was asymptomatic, but had low tracks at birth repeatedly. The mother and the father who I met are distantly related, and the parents reported distant history of SCID on both sides of the family, but they only knew of the disease by rumors and telltales in their group as a Rett disease. So they didn't know much about what it was the foundation of SCID, what was really wrong with SCID patients, what part of the immune system could be affected, but they knew of SCID as a Rett disease, which I described to you based on the Oman syndrome paper. I also had the pleasure of meeting the grandparents who were very involved in the care of this child. And they tried to also make more sense of how could this be happening, that there is an infant with low track in their family when the mother and the father are so distantly related. So soon after that, we started to investigate the baby. And as you can see on the chest x-ray, there was no thymus detected above the heart, which is an important matter that could relate to the fact that the immune system is not developing properly, as you need to have T cells come to the thymus to make the thymus grow. In fact, the patient had no T cells, no CD4 and CD8 T cells, no B cells. The absolute lymphocyte count was 300, which was primarily because of the presence of natural killer cells or NK cells. The baby had IgG of 867, which is normal, and we believe that this was coming from maternal immunoglobulins throughout the pregnancy, but had full absence of IgM, IgA, and IgE. When we looked at the proliferation, the multiplication of lymphocytes with mitogen, it was absent. So that together made us believe that this child had a phenotype of a T minus B minus kid, which means that both the T cells and the B cells were absent, but the natural killer cells were present. And we immediately started HLA typing the patient and the family members, and we were fortunate to see that the brother was a match. But beyond understanding that this child has a SCID, we felt that it was very, very important to understand the genetics. What is the gene behind this SCID? And as I'm talking to members of the community, it is becoming more and more obvious that some members of the community may question, why is it important to know genetics? They're gonna be SCIDs and they're gonna be taken care of by transplant. So this presentation is actually for those of you who believe that SCID alone is sufficient for you to know and everything will go well after, because we actually want to present to you that you really need to understand what is behind that SCID disease, what is the genetic reason, since it can really help to improve the treatment outcomes and tailor therapy for the baby. So our patient, we were notified by Dr. Stan Goldman from Texas about the extended family and 2 additional relatives with recent diagnosis of SCID by newborn screening at Johns Hopkins and CHOP. And I will mention our collaborators, Dr. Heimel and Dr. Beth later. And the patient was transferred to Texas to Dr. Goldman's practice for further management. So we sort of lost direct communication with the family, but we started to follow things a bit from the distance. And what happened in that distance is that around day 42 of life, this little baby have developed the rash disease. So as you can see, there is a diffuse erythema throughout the entire body of the baby. He is very uncomfortable. His lymph nodes becoming big. And that tells you that he is really becoming more of an Omenn syndrome inflammatory phenotype. And this was as he was waiting for his transplant. And then we were fortunate to see that after he received transplant from his brother on day 72 of life, his rash disease has improved and he's in his mother's hands, much happier, doing great. So first, I would like to introduce you the concept of REC deficiency and then tell you the implications of this disease in the advocacy project that we are working on with SCID Compass. This is a very simple slide that sort of shows you that the REC proteins are extremely important because they have to bind the DNA and have the B cell and T cell receptor DNA region to recombine. And this reshuffling of the segments will generate a diverse T and B cell receptor repertoire that will protect us from infections. What happens in REC deficiency is that in the full absence of these proteins, the patients will not be able to make T and B cells in the bone marrow, and therefore the phenotype of T minus B minus SCID will emerge. These patients, as you have seen with the family history of our index case, can have severe infections, fail to thrive. They will have no T cells or B cells, so we can pick them up on newborn screening, and they have no immunoglobulins later in life. So we really have to transplant them in time. And then if they stay a bit longer with their condition and the T cells become inflamed and stimulated, they can actually expand in the patient and cause this very unusual reddish eczematosus phenotype, which we call Omenn syndrome. And by that time, you would have a high elevation of IgE with the absence of IgG and the high inflammatory state. When we look at the T cells, there are some T cells in the periphery, which could be misleading, but looking at the repertoire, we see a significant restriction or oligoconality. And although we will not talk about this through the Irish traveler experience, but we are seeing more and more patients with a new variant of REC deficiency, which is basically a later onset phenotype, where the patient will have some immunoglobulins and low to normal IgGs, but develop severe autoimmunity. And what we learned throughout these experiences is that patients who have SCID and Omenn syndrome will have very low leg activity, very low presence of the T cells and the B cells, whereas those with autoimmune phenotype will have more and more T cells and B cells, but they will be dysregulated, and that could cause the autoimmune disease. So the rash disease, again, has been known for a long time in this community, and Dr. Goldman has kindly shared his slide with us from one of the early cases when the child had a severe dermatitis before, and that nicely resolved after therapy. This is another image from Dr. Goldman's collection, and you can see the impressive scaling of the skin and redness with Omenn syndrome. So Dr. Goldman, at the time when we met about our index case, has kindly shared the initial cohort that he created of 9 patients since 2003 who have been under his care. And he also mentioned that since 2008, they have been promoting sequencing of patients for their immune genes and found that the reg variants were very diverse. Some patients had the same mutation, as you can see here, the 775 deletion, but then some patients actually had a different mutation, the R897. So what is important is that there were 2 different types of SCID basically present in the community that was followed in Texas. The SCID type 1 patient had one of each of these abnormal alleles, the 775 del A and the R897X, whereas the other SCID patients had only homozygous or the same allele of the 775. So this already gave some diversity to the SCID patients in this community. Just to educate our audience here and those of you who are fellows or trainees or doctors, whenever you get a report on reg variants, it is very important to get into the details. So both variants were claimed to be pathogenic based on the in vitro report. And when you look at the small fine details, it is also obvious that none of these variants were present in population databases. There was no exact frequency. And why is it important? It sort of tells you that probably these variants are narrowed down to certain communities, and therefore the heterozygous carrier rate in the general population is very low. And this is important in light of what we found within the Irish traveler community, because what we found there, as you will see later, is that they actually have a very high carrier frequency. And that makes us think that probably there's a founder variant that we are facing. You also want to understand the evidence behind the functional consequences of these variants. And what it said here is that experimental studies have shown very little reg effect in both cases. And in each case, there could have been a disruption of the protein function or size or length. And therefore, overall, it would not make the reg protein work well. I would like to give a big shout out here for a variant curation expert panel who has been helping us with many of our reg variants. And for parents and patients to understand the importance that whenever you see a variant, you want to get the best possible curation of that variant. So there's a strong teamwork going on right now behind the curtains with ClinVar and ClinGen when we actually are resolving all of these variants on the genetic level, on the phenotype level, and functional assay level. So whenever you see variants, please make sure you fully understand how much evidence is behind that. So going back to our index case, which was patient number 1, he was a compound heterozygous patient, developed Omenn syndrome, did well after transplant. And we had 2 other cases, we call them SCID 3 and 5, referred to this Lilly study from Johns Hopkins and CHOP. And these patients also had a SCID or SCID-Omenn syndrome phenotype and did very well with transplant. And again, I want to emphasize to you that the variants that we saw here was compound heterozygous in 2 cases and 1 homozygous. So why is it important to have a compound heterozygous variant? And I'm just going to go back to this slide for 1 minute, because what we learned basically is that one side of the family was carrying the 775 variant, whereas the other side of the family carried the 897 variant. So it was truly, truly real what we heard from the grandparents and the parents, that their families were distant. They were not carrying the same variants. But as these two distant families met and there was a marriage, by carrying these variants, eventually put a child at risk of having SCID, even in an unexpected way for them. So when we looked at these variants on the bigger scale of what is going on in the world, we started to collaborate with doctors from other parts of Ireland and England. And we learned from Dr. Leahy, Dr. Sally Lynch, and Andy Jennery that they have indeed identified patients within their communities with the two variants that we have seen in the United States in this kindred. But the number of cases that they have seen were much less than in our community. In fact, all of these variants that I list here were only reported in individual cases in transplant centers or by reports of the groups in meetings. So quickly just summarizing that our patient received rabbit ATG, busulfan, cyclophosphamide, and GVHD prophylaxis. And with that transplant regimen, he did very well. And the rest of the group that was followed by Dr. Goldman, up to 9 patients, is now recorded with different regimens. Some of them had sibling donors, some of them received cord, but no matter what, all of these patients did very well, and they became IVIG dependent after they reconstituted their immune system. However, a twist on the story is that Dr. Goldman has basically followed 3 community members, patient 2 on the left and patient 3 on the right, were ragged, but there was a little kiddo in the middle who also has received transplantation. But it was unclear why is he so different than his other relatives. And that was an unsolved mystery in this community until we had another baby born and identified by newborn screening. So this baby, not soon after our little child in Florida, a second baby was born in Texas. And at day of life 1, this baby had the rash disease. So it was already immediately known that this baby had some inflammatory state. She also had intrauterine growth retardation, so her size was smaller than expected and had absent tracts, and the T cells were around 300 at birth. The patient had to receive very early in life rabbit ATG just to try to control the severe dermatitis and all the distress that she had from the illness. At that time already the T cells were as high as 17,000. And it was very surprising to see that the RAG sequencing came back normal, which sort of was expected that maybe this child would have another of the combination of the 2 RAG variants. And when we went further with following this patient, the patient received tacrolimus therapy to calm down the rash. And eventually we had the chance of getting a sequence back from the company who sequenced it. And we were very surprised to see that there was a new genetic defect in this community with non-homologous end joining 1, when there was basically a 1 nucleotide deletion that resulted in a frame shift and the shortening of the protein. And what is the importance of this variant? This non-homologous end joining 1 variant in homozygous form actually can cause a very different type of SCID, although the phenotype is still T minus, B minus, but since it is important in not just the VDJ recombination, but DNA repair, these patients were at higher risk of complications. So the implications of finding of this gene in this family was that this baby needed less toxic regimens, and there could have been neurological sequelae of the disease, basically complications beyond the immune system. So what we learned about this patient is that by her being a different genetic, having a disease due to a different genetic cause, that really put her in a new category. And she didn't only just have SCID, but she had the intrauterine growth retardation. She had a disease that was radiosensitive. She had a much more complicated course And even against all the best efforts of the team, the patient did not survive her treatment regimen and died. So this is a very important figure, but I would like to highlight to you that knowing the difference between which gene is causing SCID has major implication, not only in the clinical phenotype, but also how to treat these patients and what is the risk of survival. So within this group now, with the help of our team members, we now collected 14 SCID patients. Some of them are still undergoing sequencing. Unfortunately, one have already deceased in the past, so we won't be able to sequence. And only one patient so far in the 14 had the non-homologous end joining gene defects. However, we suspect that that little boy that I showed you in the picture may be also someone who would be having the same genetic defect of the non-homologous end joining gene. So how to find SCID patients in this community and how to have the community to be prepared for the birth of a child with SCID. Before newborn screening, we actually, Dr. Goldman shared with me that they had a little piece of paper that these families were carrying when they basically just said, make sure that you get a CBC, an IgM, and T and B cell immune phenotyping. If you can, try to get peripheral blood testing as soon as possible when you see the rash disease, so we can get you to the right doctors in time. But that, sometimes take time because the rash disease would not come immediately. In some patients, it took actually up to 3 to 4 weeks for the rash disease to come. So now with newborn screening for SCID, it is much easier because at the first days of life, these patients will have a track screening for the presence or absence of the T cells, and we would be able to find them right at birth with SCID. However, knowing that there's a community with high allele frequency of SCID genes, is there actually a reason to go further than that and help with variant testing of carriers? So this is a little summary of the family pedigree of our index case and other cases diagnosed by newborn screening. And you can see that some of the family members who already had SCID phenotype in earlier generations were born without much knowledge of the carrier state of the parents. And this was the reason why we decided to start an advocacy project and work with the SCID Compass team and try to look at a much bigger resolution of the carrier state and the presence of SCID variants in this kindred. So we wanted to look at carrier state and see how we can help families to be educated on that. And that is sort of a summary of the meat of our current data that is hard work of Evan Potts and many of our team members. And what we have done is we created a pedigree of 160 case kindred that includes 12 SCID patients, and there are actually 6 extra patients that we find by chart, but we could not place on this kindred yet. And within that 160 case of kindred, we already screened 44 family members, and 16 of them were carriers. So that tells us that there's a huge carrier rate within this kindred of SCID genes. And whoever is in the audience from these communities, please consider reaching out to us for understanding your carrier state so we can continually advise you regarding risk in your family for the birth of a child. What we also learned is that it's important to know, is this truly a variant within this kindred, or could we assume that this is going to be a founder variant? So by looking at the pedigree, we learned through all your help, the help of the family, is that 2 family members directly immigrated from Ireland, and there is some distant relationship to the first SCID patient who was transplanted from this community. So we assume that it is likely that the genes, that at least the reg genes, that they were coming from Ireland. However, it is still unclear whether this Black non-homologous end joining gene was coming directly from somewhere else, or was it just acquired in the United States? So what are our social challenges right now and how to increase awareness? In the past year, at least 4 babies were born with SCID. So that tells us that we have to be really prepared in the Irish travel community for the birth of SCID babies. And therefore, we think that we need to continue our genetic screening program for carrier state in this community. And we would like to encourage all of you, all the physicians and care providers who provide for these families to consider working with our team for that. We think that there's an opportunity to find carriers of the genetic variants and that can predispose them for SCID. And therefore, our advocacy program with IDF and SCID will continue to do carrier state testing by saliva samples. We would like to publish the current findings of the clinical and social challenges, and there's a manuscript in preparation. And we would like to streamline possibly amniocentesis, early genetic testing, and HLA typing for donor selection. In summary of my presentation, we identified 3 distinct SCID gene variants, 2 RAG1 and 1 non-homologous joining in the same community. We think that there's a high risk for birth of a SCID child among the Irish travelers, and therefore there may be a need to support carrier screening in this population. It is also very important to distinguish whether a child will be born with a RAG1 or a non-homologous joining radiosensitive SCID, since there's a very different risk and outcomes depending on the underlying genetic disorder. And we still don't know, but there could be some health risk of carriers. We are looking into family members who develop malignancies. There could be some risk of autoimmunity, possibly with carrier state. And this is something that we would like to continue to investigate within this community and beyond in other communities. So overall, we believe that there's a high need for advocacy and education in this geographically dispersed, but otherwise very tightly knit community. So we are building a team to have these families, and please join us. Currently in the United States, we have been building connections with Dr. Heimel at CHOP, Beth Younger at GHMI, and we also are very grateful to have communication and collaboration with Sally Lynch, Ronan Leahy, and Andy Jennery from Ireland and the United Kingdom. I also would like to thank very specifically some of our important team members. Dr. Shilpa Taung, who is a fellow, has actually received a GME USF grant for SCID advocacy, and she built a beautiful educational video with Evan Potts together to educate on SCID. And we highly encourage all of you who are interested in learning about this video to consider filling out some of our questionnaires before the video and after to see how much information you could retain from this educational setting. I also would like to thank specifically Melis Yilmaz, who has been helping us with the pedigree generation, along with Evan Potts, who is now in the MD PhD track at USF, and he's heavily involved with the Irish communities. I would like to thank Joseph Dasso, MD PhD, who will be promoting microbiome screening in these families, and our core team, Christian Chomos and Bogdánka Ujhazi, many of our fellows and students who are all listed here. For funding, we are extremely grateful for the SCID Compass, HRSA grant. We are also having similar advocacy projects with the Mennonites under SCID Angels, have an R01 JMF and Robert A. Good Foundation project. And I'm just very grateful that our laboratory is almost 10 years old. We started in Harvard in 2013. And by 2022, our team is just continually growing at USF. I'm really grateful for our patients and families, and in particular, Patty and her family, who has been kindly sharing their journey with me and going through that journey. And this little boy's successful story is encouraging me to continue to push for education, advocacy, genetic screening, and the best possible treatment for SCID patients. Thank you so much for your attention, and I'm ready for your questions. Thank you.
Thank you so much, Dr. Walter. That was wonderful. And of course, we are so excited to hear more about the study once you have your findings to share. So thank you so much. So it looks like we are having some technical difficulties with the chat, so I'm not sure that folks were able to chat in their questions. But if you have questions for Dr. Walter or for SCID Compass, certainly consider emailing them into us, and we will try to address them that way. All right, well, thank you so much again, Dr. Walter. This concludes the first day of our 2022 SCID Compass Summit. Thank you so much, everyone who joined us for day one, whether it was for one session or all the sessions. We really appreciate you being a part of this important day. And we will see you tomorrow at 11 a.m. for our first session of day 2 of the SCID Compass Summit. Thank you so much, everyone, and have a great rest of your day.
Thank you, Emma. It was wonderful to be here. Thank you,
Thanks, Dr.
everyone.
Walter.
Bye. Bye-bye.
Bye-bye.